Hello, my name is Manesh Patel, and I'm the Chief of Cardiology and Director of the Heart Center at Duke University. Thanks for joining us on this program where we evaluate how we assess the burden of atherosclerotic disease in our patients that we see in clinic. The history and physical exam is key to evaluating our patients and understanding the burden of atherosclerotic disease. And this is a key step because we often want to understand, do they have past history of vascular disease? That might include a stroke, a TIA, and you also want to understand, do they have pain in their legs? Do they have claudication? Additionally, the burden of atherosclerotic vascular disease should be thought of as how many vascular beds are involved. Where is the burden? Where is the atherosclerosis? And this helps us stratify our patients. Examples of patients at risk for atherosclerotic cardiovascular disease are patients that you probably see in clinic all the time. Those include patients that are smokers, patients with type 2 diabetes, those with atherosclerotic lipid disorders, people with hypertension or chronic kidney disease. As we know from the American Heart Association, knowing Life Simple 7 and thinking about those things that we can do to prevent cardiovascular disease, a lot of these risk factors and behaviors are tied in to type 2 diabetes, tobacco use, lipid disorders, hypertension. So managing these risk factors is critical to improving your patient's outcome. Now, an example of a patient such as a chronic coronary artery disease patient, but a patient who has no symptoms of peripheral vascular disease, it's important to see if you can elicit that. That means a focused history and physical. Does it hurt when you walk? Here in North Carolina, where I take care of a lot of patients that are out and about, often this is, does it hurt when you walk when you go to the grocery store or when you're working out in the yard? Do you have to use a cart? Do you have to stop because your calves are hurting? Have you noticed skin breakdown in your lower limbs? Is there a lack of hair on the lower extremity? Are there no pulses? Is there venous stasis? Some of these findings on physical exam will trigger you to think about an ankle brachial index, a key test for patients with PAD. The ankle brachial index is a test where we check the blood pressure in the arm and the blood pressure in the legs. And as we tell our patients, if the blood pressure is 100 in your arm, it should at least be 100 in your legs. We take the highest number in the legs and compare it to the number in the arm. That's the highest number. It's important to recognize that 0.9 is normal and anything below 0.9 is abnormal. And the lower you get, the more vascular complications the patient may have and more burden of atherosclerosis they have. What about the symptoms that you may elicit when you're talking to your patient? This is important, again, when you think about a detailed history and physical. And the key is to characterize sort of the features of the pain, if it's associated with activity, and the location of the pain. On this figure on the slide here, you can see that if a patient has buttock pain with walking, that's not often thought about as claudication. But in fact, common iliac artery or iliac disease leads to that. Thigh pain on exertion is often tied to common femoral disease. And the most common that we hear about often is calf pain, walking and feeling your calf tighten and then having to stop and release that. Often I'll hear patients, as I said, using the grocery cart to stop and see if that calf gets less tight. That's often associated with superficial femoral artery occlusions. And of course, if you have an aortic issue, the entire limb could be at risk. But these claudication symptoms aren't exactly as I've described them. Many patients will have atypical features. And so in addition to getting this history, it's important to see when they walk if they have this pain. Now, we know in our patients with PAD, it's important to elicit if they have it because prevention strategies, known therapies to prevent cardiovascular disease are unfortunately tremendously underused in our patients. This paper by Jeffrey Berger shows that in a large outpatient practice, that even though patients might be known to have PAD alone or PAD plus CAD, they have a really low use of some of these strategies. What's notable is patients just with lower extremity peripheral artery disease. It's 30% use of an antiplatelet, 30% use of a statin therapy to lower their cholesterol, and woefully less smoking cessation or tobacco counseling. And of course, we know exercise is important for these patients. Even though they're having pain in their limb, one of the first things we can talk about is increasing their exercise activity to hopefully build collaterals and build more blood flow to that limb. This paper by Sumit Subbarwal also showed that, in fact, it's not just that they have lower use of these therapies, it's the trigger in the clinician's mind. Coronary artery disease seems to trigger use of these therapies. And if we use CAD as the benchmark, we see that patients with PAD alone, or even those with PAD plus CAD, actually get less use of those therapies, even though their burden of atherosclerosis is likely higher. And this is both with antithrombotic therapy, ACE inhibitors, and statins, as you can see on this slide. Now, patients with peripheral vascular disease often have disease in multiple vascular beds. The term polyvascular disease is a term that Deepak Bhatt coined, and it helps us think about all the places people have cardiovascular disease. I think of this as places where we think of things we have as problems for our patients. We always think about coronary artery disease because heart attacks are certainly one of the largest problems patients have, but certainly stroke, carotid disease, lower extremity vascular disease, and in fact, kidneys and other vascular beds can be shown. This figure here tells you that the total burden of atherosclerosis likely points to where the disease is. So the more atherosclerosis you have in your carotids, the more likely you're going to have a stroke. The more atherosclerosis you have in your limbs, the more likely you're going to have a lower extremity evaluation or need for a procedure. And unfortunately, hopefully we can prevent amputation. So hopefully you've learned from this session that getting a key physical exam and history will help us think about our patients with atherosclerotic cardiovascular disease. Importantly, I often say shoes and socks off, right? If you want to examine the patient, I tend to start at the bottom, feel their pulses, look at the legs, talk to them about if they have any pain in their legs, examine the femoral pulses, talk to them about if they've had any problems eating or drinking and having the abdominal aorta examined. And then you think about the routine questions we think about for cardiovascular and cerebrovascular disease. But that key exam with an ABI and risk factors will help you understand if the patient has claudication, to rule out vascular disease in patients with PAD, and those with polyvascular disease, recognizing there are a lot of proven therapies that they need. So thanks for paying attention to this session on atherosclerotic cardiovascular disease and how to assess the burden in our patients.